Good afternoon. My name is Bill Richards. I was the moderator for today's sessions on foregut. I'm sitting here with Paul Taganides, who did a wonderful job discussing the aspects of gastroesophageal reflux disease. And you made the point about that GERD is not symptoms, but what is it, Paul?
So, first of all, I can't thank you enough, Bill, for letting me be part of this. What a great program and great way to introduce something that I feel is a huge problem in healthcare today that is poorly understood, and we need to get a better handle of it. And currently, people associate the diagnosis and treatment of reflux disease on symptoms alone, and we need to, as surgeons, if we want to properly involve ourselves in this disease process, understand that it's much more than that. And it may not be just the sphincter, but the lower esophageal sphincter is critical, and the understanding of the lower esophageal sphincter is critical in understanding this disease and therefore treating it.
Right. We had some of our exciting sessions was when our gastroenterologist, Brooks Cass, talked about the use of PPIs. And even Dr. Cash admitted that there were some patients that have severe reflux and that they may be best treated with operative intervention. Do you think that's a fair assessment?
Absolutely. And I think more and more our gastroenterologic colleagues are recognizing that this is a disease that is plaguing them in their offices because as the disease goes forward, it becomes much more difficult to control just with medications. And as you pointed out, they focus on symptoms and not on the actual disease. Don't even get me started on the facts that we develop Barrett's and neoplasia with chronic reflux. And the data around chronic PPI use and their safety is also starting to mount, and it's going to create a huge problem if the FDA determines that we can no longer sell these as over-the-counter agents, which I predict is coming down the road. And so what are we going to do? We need to be ready for this. And even if we don't include the future, currently people are unsatisfied, and our GI colleagues know this. We need to educate surgeons how to better treat this disease so we can handle the volume that's going to be coming to us someday.
Yes. And then we had an interesting debate between Dr. Taganides and Dr. Olechnikov. Dr. Olechnikov took the position that the laparoscopic Nissen fundoplication was the best treatment of GERD. And you took the position that the magnetic sphincter augmentation of the lower esophageal sphincter is the best operation. So how do you think that went?
I think it went very well from the perspective that we enlightened people on the major differences between the two procedures. The biggest issue today for me is that the Nissen fundoplication, which is an excellent operation and works very well when properly done, has several major faults that are keeping it from being used in treating people with GERD, keeping people like you and me to take care of people with significant disease. And one is that it has significant side effects and long-term complications that are preventing patients from seeking out this therapy. Right or wrong, they're not seeking it out. And even more importantly, our GI colleagues, some of them absolutely refuse to send patients for Nissen because of the fear of the complications and the side effects, real or not. The magnetic sphincter augmentation, or LINX device, has radically changed my practice simply because it's a new technology that not only has excellent long-term safety data and efficacy data, but it's a new technology that's interesting to GIs and patients alike, and finally getting those patients that really do need therapy into my door so we can discuss options. And as an option, it's far more pleasing because it's removable, it's reversible, the side effects aren't there, and I'm hoping that this will stimulate the conversation that needs to occur between GIs and surgeons to really get a hold of this disease because it's plaguing our nation.
I think one of the other things that we heard from the audience, we had a number of the participants that had difficult patients that they wanted some options about. And what struck me was that the responses from Dr. Cash, Dr. Olechnikov, and you, Paul, were almost universally, let's do more studies. Let's do high-resolution manometry. Let's get a good 24-hour pH study off PPIs, or do impedance studies which identify non-acid refluxate in patients that don't feel they can get off the PPI safely, to work up those patients and identify what the best treatment algorithm is.
Again, absolutely right. And more, I think even GIs that were refractory to working up patients are recognizing that without objective evidence of disease, it's very hard to offer therapy that in many people's eyes is very aggressive. We call it minimally invasive. We're very proud of the fact that we took something that split people open from stem to stern, as we used to say, and now reduced it to some minor incisions and recoveries that in hours they're home. It is still a major intervention. We alter people's anatomy, we put them at risk on the table, and before we do that, we truly need objective evidence, in my opinion. And I think more and more, all across the team, we're recognizing that it's no longer a simple thing saying, you sound like you have reflux, so let's operate on you or put you on a drug for 20 years. So I was very glad to hear that all of us were in agreement that objective evidence really is necessary and a full, thorough workup to define the disease rather than just simply saying someone has something.
And I think the other thing that struck me was that Dr. Lechnikov put forward some data about the safety of the laparoscopic paraesophageal hiatal hernia repairs, and indeed, doing a thorough workup before you do those repairs.
Absolutely. I mean, multiple studies have shown that if you properly work up people and get the right people on the operating table, you're going to have better outcomes. It's a simple logic. If you operate on people that don't need something, they're not necessarily going to do as well. So I think that's something that more and more conferences like MISS here are hopefully going to instruct our colleagues that are out there, not at academic centers or high volume centers like we have the pleasure of being part of, that small or big, doing the right workup on the right patient will lead to great outcomes, which is what we're ultimately all for.
Yes, absolutely. There was a little bit of, pushback about whether or not this magnetic bead augmentation of the lower esophageal sphincter should, where do we stand with that? Are there hidden complications, or are there complications that we need to fear about this new technology?
In a simple word, no. I mean, we have excellent data now that spans over 8 or 9 years of human implantation. And that data ranges from smaller studies that we used to get the approval by the FDA that now have just recently got published, the 5-year data showing no adverse events at 5 years in the same population group that was studied all 5 years. We have a recent publication of the first 1,000 implants worldwide. And what's impressive to me is that this data is collected from multiple different centers across multiple different continents and countries and states, with different expertise levels at each one of these, community surgeons versus high academic volume centers. And the safety profile is identical and the outcome profile is identical. So we're talking about finally a procedure that as surgeons, we can truly reproduce at any level of expertise. But based, of course, like we said before, that you pick the right patient. So I can tell you that to date, there have been no long-term erosions of this device. They all occur within the first 2 years, which implies that it's probably the early implantation-related phenomenon. And then long-term, even with explantation or removal, it's an outpatient procedure and no serious adverse events to date.
Okay. I was also impressed, Dr. Cash talked about deep enteroscopy, about examination of the entire GI tract, and video capsule endoscopy. I mean, we're doing more and more not minimally invasive or totally non-invasive endoscopic procedures. What did you get out of that?
First and foremost, that I'm very glad that he's doing it and not me. Clearly a very involved process. I've never had the fortune of personally doing a deep enteroscopy, but it must be quite a deal. And your comments at the end about the fact that if you have the people that need it most tend to be these frail older ladies, and we know that if you push a little too hard in the wrong way, you get all kinds of injuries. So I applaud their fearlessness in doing this kind of procedure. But it's also a testament to how much technology needs to grow to help us define these things. Because years ago, we had trouble defining something simple. We would do laparotomies. I can remember yesterday, like it was yesterday, my attending in my residency saying, "Why are you thinking? Lap them." In other words, just cut them open and find the diagnosis, Paul. Well, now more and more, obviously, people don't want that done. And deep enteroscopy and capsule endoscopy and all these technologies are really just a start into how we can further help define foregut problems in a minimally invasive way and help people.
Well, I think it was really an extraordinary session. We learned a lot about some new technology, some real advancements, I think, in the treatment of gastroesophageal reflux disease. We're looking forward to later tonight some more sessions talking about achalasia, the POEM procedure, and Barrett's esophagus, where again, we're seeing pretty dramatic changes in the way that we look at and treat Barrett's.
Yes, and it's an epidemic that's hitting our country, and we need to get a hold of it before we already have an epidemic of adenocarcinoma, but before it gets out of control, though, because it's a terrible, terrible disease. And I'm very excited to see the sessions this afternoon, and I'm glad you invited a zealot like myself to be a part of it.
Yes, you put in your conflicts of interest that, you were descended from?
Alexander the Great, yes.
As well as being a GERD zealot.
Correct, correct.
Thank you, Paul.
Thank you, Dr. Richard.